So thank you to James for the invitation to speak tonight. I do want to speak about the department's expectations, but because we do value this work, I also want to talk about how the department can support this work. Now, how do I go? I'll try that. Excellent. So from my point of view, we would support an audit locally or nationally because it provides us the assurance, or not, that the care that we provide is safe, effective, and appropriate to the patient's needs. In a state like WA, where care is provided across a wide range of hospitals, it also gives us some measure of the consistency in the standard of care that we do provide. If we were to take this nationally, we would really appreciate that because it offers us the opportunity to benchmark with others. And by having that non-WA mirror to our performance, it allows us to support change and improvement. I'm very keen that any clinical improvement or change is driven locally. And so we would support audit because the data derived from that actually gives data back to the clinicians to have the conversations they need with the hospital executives and other budget holders. And I think if we were to do this nationally and we did identify variation in the standards, we would very much welcome the development of clinical care standards by the clinical experts, which we can help to assist in implementing. So that's all I'm going to say in terms of expectations. And now I want to talk about how we can support hospital-based quality improvement activities. I don't usually put legislation as an enabler, but I have tonight. And I do also want to talk about a few tools and programs which are going on. So we are in the unusual situation of having legislation which is very clear and explicit about our responsibilities and also the responsibilities of the health services. So the Health Services Act essentially outlines the responsibilities of the DG in terms of overseeing, monitoring, and promoting improvements. It also goes on to talk about the responsibilities of hospitals, and in particular of your boards, in terms of monitoring and improving the quality of services and having in place appropriate corporate and clinical governance arrangements. It also alludes to the responsibility to comply with applicable policy frameworks. So on which note, these are mechanisms by which the system manager can outline their standards or expectations of care. So you may be familiar with some of those which already exist around clinical incident management reporting, around credentialing, and around review of death. And there are others which we are exploring the option of, including things like the safety and quality monitoring policy, in which we're toying the idea of including audit, as well as an indicator set as a minimum data set so that we can benchmark hospitals. We are also looking, having had the conversation about risk assessment early on, about having a similar sort of policy around risk assessment of patients and the use of screening tools. Some of you may be aware we've had a review recently on safety and quality in the WA health system, which usefully for us, I think, articulates some of the issues around clinical risk management and the need to pay heed to the impact of non-clinical decisions, the need for clinician leadership, transparency in the reporting of safety and quality performance information, and also reinforcing the need of audit. So if I move on to some of the clinical audit tools that we do have, this is one which some of you in the room may be already familiar with. It's the Quality of Care Registry. It's essentially a web-based program that clinicians can use to upload a questionnaire and input data into. From my point of view, it probably saves pulling out the medical records and sitting in the room by yourself and going through the notes. So this is a module that was developed by the clinicians involved in looking after fractured nerve patients. What they've done is collected the patient information, the usual demographics. They've collected information relating to took the patient to hospital, information about the patient's pre-op status, about the surgery itself, and of note they've included the ASA score, whether there was a delay to surgery, whether the consultant was present, and so on, and then information about the discharge. So these are some of the options available. My next slide, I just want to sow the seed of an idea. Because clinical audit's great, but you don't get the result on the track. Wouldn't it be useful if we had the data in a more timely fashion? So I'm thinking along the lines of a run chart. So this is the VLADs. It's not available for PILA, but I'll walk you through it and you can think about it. So across the x-axis, you've got patients as they come in through. In this case, it's a particular hospital that's looked after AMI patients. On the y-axis, you've got statistical lives gained, if it goes up, or lost, if it goes down, if the patient dies. The black line is your hospital. The blue and red lines are a little bit like confidence intervals. So what we do is we get the data for the whole state, we calculate the state average. If you were performing 75% better than the state average, you'd be where the blue line is. If you're performing 75% less than the state average, you'd be where the red line is. And our suggestion would be if your line, the black line, intersects with the red line, you might want to investigate what happened in that case. So you can click on that case and you can pull up the unit number to get the records. What you can also do is look at the cases that preceded that particular index case. You can pull up the unit numbers, in this case when they died, and their predicted risk of dying. So I would be going back and looking at the patient who died on the 22nd of April, for example, because they had a low expectation of dying, and trying to understand what happened. Just sowing the seeds there. Going to move on to some other projects that we've got going on which may be of interest and which may be helpful to the group locally in terms of supporting PILA. So one is the High Value Healthcare Collaborative, which is chaired by Simon Tyler in the audience. And some of the projects within this umbrella include a Smart Sepsis program, which is actually run by Fiona Stanley Hospital and PEF West. And what it looks to is to improve test ordering and specimen collection with less contamination, for example, to have a comprehensive sepsis pathway for acute patients and for patients who are subacutely unwell, and also to improve that translation of that test result to prescribing. And the last project I want to talk about is the Goals of Care project. So this has been piloted in most of the tertiary hospitals and a few of the general hospitals locally, and essentially it looks to identify patients as they come in and allocate them to whether they should receive all life-sustaining treatment or down the spectrum to comfort care. So in summary, we're very supportive of the clinical audit activities and how this, and in particular interested in how this will roll into the hospital's clinical governance process. We're very happy to support with assistance in developing or aiding access to local and national resources. And if need be, we can encourage by monitoring and mandating where necessary. And I think I want to finish off by talking about the importance of transparency in reporting. That's the undercurrent which has driven a lot of the work behind the safety and quality indicator set, and also the work around developing the cubes of cancer activity and looking at outcomes there. We've had multiple conversations with James and WAASM around QP, and I'll just leave the podium with the thought that we have 3 remaining committees in the public sector who have QP, and they've asked to be relieved of that. Thank you.